In 2018, California Health and Human Services Agency introduced the California Integrated Core Practice Model, or ICPM. ICPM builds on the shared values and core components and standards of practice featured in many prior teaming models, including 1985's System of Care, Wraparound in 1997, the Mental Health Services Act, Child Welfare Redesign, Team Decision-Making and Family Group Decision-Making, Safety Organized Practice, KDA Pathways to Wellbeing, Residentially Based Services, and Continuum of Care Reform. ICPM incorporated the values and promising practices of these approaches and models into a comprehensive approach and standards of practice for child welfare, juvenile probation, county mental health plans, and their partners serving California's children, youth, and families. The practice of working together as a team is at the heart of ICPM and central to the implementation of family-centered practice and CCR. The ICPM sets the child and family team as the primary vehicle for the team-based process and is implemented in 4 phases: engagement, service planning, monitoring and adapting, and transition. Together with the CFT process, the ICPM establishes an authentic partnership with children, youth, and families, which results in coordinated and integrated plans that are individualized to address the unique needs of each child and family member, working together towards well-being and permanency. Additionally, the ICPM helps create a culturally relevant and trauma-informed systems of care that strengthens the voice and choice of the child, youth, and family and builds consensus around their strengths and needs in service planning and delivery. In January 2018, Department of Healthcare Services and California Department of Social Services jointly issued All-County Letter 18-09 and MHSUDS Information Notice 19-007. CDSS and DHCS recognize the Child Adolescent Needs and Strengths, or CANS, as a multi-purpose assessment tool developed to assess well-being, identify a range of social and behavioral health care needs, support care coordination and collaborative decision-making, and monitor outcomes of individuals, providers, and systems. Department of Healthcare Services, DHCS, selected the CANS as well as the Pediatric Symptom Checklist to measure child and youth functioning. Some county jurisdictions were already familiar with this use of CANS by behavioral health to measure child and youth behavioral health functioning to establish medical necessity for mental health therapies. Additionally, pursuant to AB 403 and the Continuum of Care Reform, or CCR, the California Department of Social Services, or CDSS, also selected the Child Adolescent Needs and Strengths as the functional assessment tool to be used with the child and family team process to guide case planning and placement decisions. The expanded implementation of CANS by Child Welfare, Juvenile Probation, in partnership with behavioral health departments as both a mental health and substance use disorder screening and functional assessment tool advances efforts already underway through Pathways to Wellbeing. Use of CANS within the CFT process promotes ICPM practice principles by amplifying family voice and choice, teaming, use of natural supports, collaboration and integration, identifying community-based solutions, according cultural respect, individualization, strengths inclusion, persistence, and a focus on outcomes. Per ICPM and the legislative directive of ACL 18-09 and MHSUDS 18-007, completion of a thorough CANS assessment requires effective engagement using a teaming approach. The CANS must be informed by CFT members, including the youth and family. CANS assessment results must be shared, discussed, and used within the CFT process to support case planning and care coordination. The CANS must be completed prior to the completion of the family case plan. CANS results are intended to inform the CFT in several key areas, including but not limited to determining if the child, youth, or non-minor dependent has unmet behavioral health or substance use needs, making placement decisions, informing the level of care protocol, determining educational needs, identifying any immediate support needs of the family or care provider, such as coaching or respite care, and/or developing a comprehensive plan to support safety, permanency, and well-being. The CANS assessment results are to be used as a shared resource for team members throughout the CFT process. The CANS results provide a platform for the CFT to guide conversations and support the process of learning more about the child, youth, or NMD and family's needs, as well as identifying behavior patterns. The CANS is the formal, continuous assessment tool used by CANS certified providers to inform the case plan goals, and it serves as the foundation for ensuring that the strengths and needs of the child, youth, or NMD and family members are incorporated into the case plan. Case plan goals are based on identified, actionable items and focused on addressing the needs for child, youth, and NMD, permanency, safety, and well-being. In addition, the case plan must include compliance with any relevant court orders. Children, youth, and NMDs receiving specialty mental health services are assessed by CANS certified providers using the CANS every 6 months. County placing agencies and county mental health plans are jointly responsible for ensuring that a single CANS tool is completed for each child, youth, and non-minor dependent. As such, county placing agencies and mental health providers must share with each other completed CANS assessments and their resulting identified outcomes for children who have been assessed and/or served by both agencies in order to avoid unnecessary duplication and over-assessment of the children, youth, and non-minor dependents. San Francisco is changing the way we use CANS. Like many other jurisdictions, San Francisco has primarily used the Parade Foundation's CANS tool as a behavioral health tool to screen children for presenting mental health symptoms that meet medical necessity for Medi-Cal-funded therapeutic interventions. However, CANS is actually designed to do much more than assess mental health concerns. CANS is a process intended to inform assessment, case planning, service planning, and monitoring. CANS is evolving from our current use by behavioral health as a mental health tool to a process utilized by behavioral health, child welfare, and the child and family team to have a common language to talk about and prioritize case planning around the behavioral needs and strengths of each family member based on how they impact the safety, stability, and functional well-being of the family. The CANS tool features 7 domains: behavioral emotional needs, life functioning, risk behaviors, cultural factors, strengths, trauma, and caregiver needs and resources. Our customary practice has primarily concentrated on screening children's behaviors to identify a need for therapy. San Francisco is evolving our use of CANS to equally focus on the needs and strengths of all caregivers in the past 30 days, including the parents and the substitute caregiver. San Francisco's current CANS application involves having clinicians interview and observe children. Clinicians also routinely interview the caregiver, and sometimes they interview the parents to score the different domains. Sometimes clinicians will complete a CANS screening and determine that the child has no behaviors that meet medical necessity and to have no service recommendations. As we expand our CANS practice to address case planning, clinicians will take an in-depth look at the child's needs and strengths. They will also balance the screening by considering the parent's caregiver resources and needs, or how the parent's outstanding needs and/or lack of mitigating resources impacted the child. All cases involved with child welfare, by design, are involved precisely due to concerns about the primary caregiver's unmet needs or lack of resources that impacted their ability to safely parent and meet the child's needs. CANS as a behavioral health tool has mostly focused on the domains about the child's presentation. CANS as a process to identify child and family strengths and needs to case plan also focuses on the parents' and caregivers' needs and their resources to be able to care for the child. In our county's current application of CANS, primary consideration has been on the child's presenting mental health concerns. However, it's important to utilize the CANS to tell the story of the child's holistic well-being in the context of the family. A baby may be doing well and have no physical, emotional, or developmental concerns in the care of a resource family, but the birth parents may have unaddressed needs. They may be struggling with mental health, substance use, supervision, knowledge gaps, be uninvolved with care, lack social support, have medical, developmental, or physical limitations affecting their ability to provide care, or have residential instability. All of these issues could impact their ability to safely care for and meet the baby's needs. In deepening our practice using CANS, we look at the child and family in context of how the family functions together, the child, as well as the parents. CANS is evolving from a tool presently used to screen mental health symptoms to a process that will assess safety, permanency, and well-being needs for each member of the child's household in order to identify what needs and strengths for each individual must be prioritized and changed for the family to function safely together. Child welfare requires PSWs to complete the Structured Decision-Making, or SDM, Family and Child Strengths and Needs Assessments prior to development and updates of the case plan. PSWs conduct many interviews with clients and collaterals, observe behavior, and review records to score the Family and Child Strengths and Needs Assessments. Who participates in scoring the strengths and needs to evaluate what needs will be prioritized for case planning? Oftentimes, a PSW makes the assessment alone based on the PSW's own observations. Behavioral health requires clinicians to meet with the child, caregiver, and sometimes the parent, and alone decide on the CANS scores. The clinician then participates in a facilitated behavioral health CFT that is designed to be a small, intimate meeting at which the clinician shares CANS findings with the parents and the protective services worker, hears the parent's perspective, and addresses any questions. CANS information is considered private mental health information protected by HIPAA. CANS integrated CFT meetings will shift and deepen the practice on who provides and collects the information about the child and family strengths and needs, and how needs and strengths will be prioritized for case planning and service planning. Parade Foundation actually intended CANS to be a communiometric tool to be used by a team versus a tool scored alone by a clinician as protected mental health information under HIPAA. Communi means group and metric means measure. Child-adolescent needs and strengths are to be informed by, discussed, and evaluated together by the family's team versus a single clinician. The clinician will still complete interviews and score a preliminary CANS tool. The CANS will only be finalized when input is incorporated from the family's own selected child and family team. The idea is to have individuals who the child and family trust, who really know the family, share their observations, knowledge, and examples of family functioning to obtain a more accurate perspective and baseline of what family functioning really looks like. Prior to meeting with their self-selected team, the child and family are asked to determine with whom they are willing to share information about their substance use, mental health, and sexual and reproductive health. Clients age 12 and older and their parents will also be asked to give general consent to proceed with the CFT meeting. The clinician will still participate in the communiometric CANS process, but the clinician role will evolve to be the CANS consultant and recorder who writes down the scores versus the behavioral health expert on the family. The clinician listens to the team but does not share personal family information or violate HIPAA. The clinician may ask clarifying questions of the team to get a more thorough picture of the child and family's functioning. The assessment process is owned by the family's team. The family and their team are the experts who share observations and examples of the family members' functioning. They ask questions and rigorously discuss the degree to which intervention is required to address a need. The team uses everyday language to discuss safety needs that require immediate intervention, needs that must be addressed long-term in case planning, and other issues that will need to be watched and may require future intervention. They may also identify centerpiece strengths that the child and family currently use to support the safety and well-being, strengths that the family sometimes uses to address safety and well-being, and resources or strengths to which they have access but don't routinely use to address their safety and well-being. In the CFT, The facilitator will use safety organized practice strategies such as the 3 questions, what are we worried about, what is working well, and what needs to happen next, to explore and identify the specific behavioral needs and strengths of the 7 CANS domains. For example, a clinician may identify worries about a child's social and developmental functioning based on observation of the child's mute response and interviews with a new caregiver in whose home the child has only been placed a few days. The expanded child and family team is invited to share stories and observations about what works well and what the worries are concerning the child's social and developmental functioning. Family, friends, and school personnel help flesh out what the child's behavior looked like on an everyday basis prior to her separation from the parents and the home. Behavior originally observed in the foster home and scored by people new to the child may be recontextualized as trauma response versus social or developmental worries. The team may identify the child's interpersonal relationships, educational focus, and supports as centerpiece strengths to address the worries and strategize how to maintain the child in her school of origin with supportive contact with close friends and mentors to support her well-being during her transition in foster care. Perhaps the child came into care due to the parent's intimate partner violence and neglect of the child's care. Through the use of the CANS process and safety organized practice strategies, the child and family team may share worries about how the parent's intimate partner violence impacts the child and how the parent's care actually looks on a day-to-day basis. The team helps articulate what safe parental interaction, supervision, and involvement with the child's care will need to look like for the child to be safe with the parents. Behavioral objectives and goals for the parents are defined by the team discussion. Child welfare routinely talks about SOP worries and wells. SOP, or Safety Organized Practice Worries and Wells, and CANS Needs and Strengths ratings indicate the level of intervention or action required. CANS has 4 level scores of 0, 1, 2, and 3, where 0 is considered optimal and no intervention is necessary to address a behavior. An SOP safety threat is similar to a CANS need that is dangerous or disabling and requires immediate intervention. CANS would score the need as a 3. SOP worries that impact functioning and require case planning are equivalent to CANS needs that are not dangerous or disabling but still require intervention. These behavioral needs would be scored as a 2. SOP worries about behaviors that increase risk to functioning may be complicating factors. These behaviors include significant history of behaviors or needs that are concerning but do not currently interfere with functioning. These are behaviors that the team would want to watch and possibly take preventive measures so they don't escalate and require intervention. They would be rated as 1s. A team may have no SOP concerns about substance abuse for a teen who has never used drugs. CANS would indicate no evidence of a need in this area and would score a 0, indicating no action is needed. If the youth actively volunteers for a peer group against substance use, this might be a centerpiece strength that the team could use to address other identified needs. Centerpiece strengths are also optimal and scored as 0. Perhaps the team is worried that the teen was caught smoking weed at school and was suspended last year, but is not known to have smoked recently, and her everyday functioning, schoolwork, and relationships remain unaffected. The CANS score may be a 1, indicating no intervention is presently required, but the team should continue to watch the behavior and prevention work may be necessary. The teen's interest in participating on the school basketball team that requires good grades, no drugs, and regular school attendance may rate a 1 and may be a useful strength to motivate the teen to abstain from weed. If SOP worries are raised about the youth cutting school to smoke weed, this is a behavior interfering with her current functioning and school attendance. CANS would score a 2. Intervention and case planning is required to address the youth's behavior. The youth's interpersonal relationship with a teacher who mentors other students at the school may be a strength to develop and also rate a 2. An SOP worry about a youth using drugs and passing out, necessitating medical attention, is a safety threat, and a dangerous disabling need requiring immediate intervention for safety. CANS would score a 3. On the CANS strengths domain, if the youth is isolated, has no natural supports, and is disconnected from community life, a 3 may be scored, for this strength, indicating that this is an area needing development. During the CFT meeting, the worries and wells identified and discussed by the child and family team are translated into CANS scores by the clinician. They provide an easy way to assess, chart, and measure what behaviors need to be addressed, what strengths can be built on, what level of intervention is required, and whether progress in addressing the behavior has been made over time. Take the example of a 3-year-old who was living with his mother. The child was found wandering alone on the street after he crawled out his bedroom window after his mother left him without supervision. Within the CFT meeting, participants may identify what is working well, including the interest and availability of the child's extended family who has occasionally supported and cared for the child. The clinician will listen to the discussion and may ask clarifying questions to determine the relative's current role as natural supports providing some care to the child, perhaps a score of 1, or whether the relatives are available and display interest but need to be developed as a source of support for the child, perhaps a rating of 2. What level of support do the natural supports presently provide, and what level can they provide? Could they be developed as relative caregivers or as an ongoing support for the child and family? Worries identified by CFT participants will include the reason the child was brought into foster care. The mother's lack of supervision that led to a 3-year-old climbing out a window unattended is a safety threat requiring immediate intervention and would score 3. Mom's substance use and lack of knowledge about a 3-year-old's developmental needs and the safety issues of leaving a 3-year-old child home alone may be scored as 2s or needs requiring case planning intervention over the course of the case. The child's emergent crying and anxiety about being left alone may also be scored as 2s and require intervention to help him cope with his trauma. Father may have been uninvolved with the child until the child welfare case. His involvement with the child may also be scored as a 2, requiring intervention to address his ability to care and provide for his child. All of the worries and wells about the child and family functioning are captured by the clinician as baseline behavioral scores and objectively recorded on the CANS. Meanwhile, using the family's own wording and language, the CFT facilitator writes the child and family's behavioral goals identified by the team on the action plan known in San Francisco as the Shared Family Care Plan. An outline of the strategies and next steps the team commits to take to support the child and family to reach their goals is also written on the plan. CANS provides an objective record of the child and family assessment and intervention level required. The Shared Family Care Plan captures family-specific behavioral goals to address the worries and what intervention strategy shall be adopted and followed by the family and their team. With CANS integrated CFTs, CANS focus shifts from service planning to case planning. San Francisco currently uses the CANS screening to determine if the child meets medical necessity and to make recommendations for specific service interventions such as individual therapy, parent-child interactive therapy, therapeutic visitation, dyadic, or family therapy. CANS integrated CFT meetings will shift the focus on service planning to case planning, monitoring, and transition. Services may still be recommended and identified as part of the CANS process, and they are contained within the larger CANS CFT case planning process. Child and family teaming strives to engage families by encouraging them to bring together people who the family trusts and who really know the family to develop and participate in a plan that will actually work for the family. The team will identify safety threats or needs requiring immediate intervention. Some members of the team will become part of the safety plan for the family. The team will identify other worries about the child and parent's family functioning that require intervention over the course of the case. They will help identify strengths to bolster the family and help the family set behavioral change goals for the family case plan that promote family safety, permanency, and well-being. The child and family team also provide moral, emotional, and tangible support to help the child and family achieve the established goals. County policy requires CFT meetings be held every 90 days to monitor progress toward case plan goals. The child and family team reconvenes with the PSW and behavioral health clinician to update the entire family about the child and family's progress. The clinician brings the baseline CANS tool for which she finalized the scores after integrating the input of team members at the original CANS integrated CFT meeting. Together, the child and family team review the last action plan goals per the shared family care plan they developed at the last meeting. Discussion is guided by the facilitator using SOP questions, worries and wells, to reflect on how the plan went. What were the parents and their team's follow-through on tasks and commitments that they made? What does the child and parents' behavior look like now? What is the team worried about now? And what is working well? During the discussion, the CANS clinician will take note of the team's observations and perspectives of the child and family and rescore the CANS tool to chart the progress the family and child have made toward achieving their behavioral goals. The team will prioritize the child and family's current, most pressing safety and well-being needs. The case plan behavioral objectives may stay the same as originally identified, or they may change based on what the family has accomplished since the last check-in and what is currently happening in their lives. The team helps adapt the case plan and strategies to support the family to achieve their behavioral change goals. As the family makes progress toward completing their behavioral change goals, the team continues to work together using the CANS discussion process to identify how to support the family after child welfare is no longer involved. In active child welfare and juvenile probation cases in which parents are no longer involved with the child, CANS is still informed by the child and family team and is used by the team to case plan around the child's needs. For example, parental supervision and care needs for an abandoned child may prompt goals of permanency and action steps to address concurrent planning. A young person transitioning to adulthood without parents may need case planning to address a supportive transition to independence, or a youth in juvenile probation being raised by a relative may need case planning and support to stabilize mental health, stay in school, and achieve a stable home environment. Think of the CANS tool like quarterly progress reports used in grade schools, with identifiable skills to master and scores indicating the family's progress. Every 90 days, the CANS integrated CFT meeting regathers all the team members who support the child and family in mastering the goals. These quarterly CFT meetings help hold the family accountable for their own behavior and also hold team members accountable to their commitment to support the family. The child and family team do not give up or blame the family. If progress on the child and family's behavioral change goals has been achieved in some behavioral domains but not in others, the team will reflect, analyze, and work with the family. They will practice with them, cheer them on, and when necessary, adjust the strategic plan with the family in hopes of finding a strategy that works for them.